My name is Karen Bond. I'm president of Restorative Medical. Restorative Medical is a manufacturer of restorative orthotic devices. These are splints and braces primarily for neurological patients. Our products, we're very proud to say, are totally made in America in Brandenburg, Kentucky. Today we're going to talk about successful contracture management. I'm not really fond of that term, but it's very well known, so we still use it, but words have meaning. And to me, when you talk about contracture management, it sounds like you're managing something. And the old thought was that there's nothing you can do about it. You just try to prevent the patients from getting wounds and suffering terrible deformities. But we know today that you can stop it, you can reverse it, and many times you can correct it. Of course, that's according to where they are in their process. But we want to keep an open mind, and Restorative Medical teaches that technology. But we're going to talk about patients with lost range of motion with or without neurological tone. I spend half my life talking about the difference between orthopedic and restorative. Orthopedic is typically after surgery or an injury. And we're told that there are thick collagen fibers, scar tissue, that form around the joints, and these have to be broken through because they prevent the muscle from effortlessly gliding on one another. Typically, a physician or a physical therapist will come in, and let's say you've had your knee in a cast at 90 degrees for 6 weeks, and they'll come in, take the cast off, and quickly open your knee to break through those adhesions and scar tissue. For that type of contracture, lost range of motion, if it's truly orthopedic and you're sure there's no chance of neurological tone, then rigid orthopedic splints would be appropriate. We teach 3 types of restorative contractures. The first would be shortened adaptive tissue. This is caused by immobility. Imagine you had a patient who was depressed. They may have some type of chronic lung condition that they just don't have the energy to move. And they sit in a chair with their body in 90-degree angles at the hips, at the knees, for such a long, and at the elbows, for such a long period of time that the tissue literally shortens to what they demand of it. And if you think about an example of this would be when I was a young girl and I wanted to be able to do the splits. And we lived in a farmhouse with a linoleum floor in the kitchen, so it was slick and I could put on socks, and I would stretch my legs, stretch. But knowing if my brother came through and pushed me down hard into the splits, it would just rip and tear and hurt needlessly. And this is what we need to think about when we're dealing with shortened tissue, is that we don't want to rip and tear and try to force the joint open. We don't re-stretch, we literally re-lengthen, but it takes a process. Something I always like to mention is dehydration plays a very important role in the health of all our patients. But contracture patients tend to be dehydrated anyway. It's very hard for them to get enough, or their caregivers to get enough fluids into their body to maintain hydration at the appropriate level. But it's much easier to deal with shortened tissue if that tissue is hydrated and it's not dried out. With our shortened adaptive tissue contractures, there are no fibers to break through. It's simply shortened tissue. So we want to work to permanently re-lengthen that tissue. What is required would be prolonged low-load passive stretch to gradually, over a long period of time, re-lengthen that tissue. And for this, we must be patient. The second type of neurological contracture is neurological tone. And this is some type of problem with the central nervous system, which is brain and spinal cord. You have to have a flow of information to and from the brain spinal cord to the extremity and back in order to go through our normal activities of daily living that we are fortunate enough to do. When a person has a problem with the central nervous system, it could be cerebral palsy, it could be a spinal cord injury, it could be a whiplash injury in the neck, Parkinson's, multiple sclerosis, dementia, Alzheimer's, any of these problems, a stroke. You can certainly have neurological tone. Basically, the muscle spindles that are in the belly of the muscle are still intact, and they're firing, and they cause muscle contractions. But the Golgi tendon organs that are the main dampening organelles are not able to tell the muscle spindles to relax. So you have a continual or intermittent inappropriate muscle contraction. Neurological tone can also be in the form of spasticity, and we all saw this when Michael J. Fox came out with his Parkinson's condition on television, and we saw what spasticity can be like. It can be severe, it can be mild, and it can change over time. The orthotic device required for neurological tone must be engineered with a flex technology to allow the patient to pull through the episode of tone with mild resistance, then gently tug the joint back to the preset degree of extension. Typically, in about 15 to 20 minutes, you will see the patient relax with a muscle inhibition. We know there's lactic acid buildup. There are contributing factors, but you will see a relaxation. We talk about a fishing pole analogy, that if you've ever touched a patient with neurological tone, this will be very demonstrative to you. If you think about the device as a fishing pole, and the fish would be your muscle. If you cast your line into the water and you catch a fish, the fish is going to fight and pull. Well, the fishing pole is flexible and it allows that to pull. Then it brings the fish back. Then the fish pulls and the pole lets it, but with tension, and it brings it back. And they go back and forth until the fish fatigues. And that is a very good picture of how our products work with the muscle, working through the central nervous system to reach that relaxation. The third type of restorative contracture we talk about is neurological tone with adaptive tissue shortening. Only after the tone is worked through and relaxed can you identify if there is shortened tissue, and then to what degree. It will start to feel kind of sticky and gummy, and you meet resistance. And that is where you want to stop, and that is when the prolonged low-load passive stretch is required to be very comfortable and begin to set the process in motion to re-lengthen the tissue. Again, you want a flex technology splint to work through that tone to reach relaxation. Then, and we'll talk about it as we go through then the process. Continually working through neurological tone to reach that muscle inhibition or relaxation will prevent the shortening of tissue, which causes the life-changing deformities. First, we must understand what is normal before we can understand what is abnormal. The Golgi tendon organ, or the GTOs, are located between the muscle and the tendon, and we know muscle is attached to bone by tendon, so it's seated right there in the middle. And it is the main dampening organelle that will tell the muscle to relax. The stretch reflex is very important, and we really need to think about that when we're dealing with neurological patients. Now here we're talking normal, so the stretch reflex is the protective mechanism of the body that when it thinks we're stretching too far, too fast, then it kicks in and will actually stop the body from that stretch. Let's say we're at the gym and we're lifting weights. Remember, this is a normal patient, and you're trying to pick up too heavy I want to say splint. You're trying to pick up too heavy a weight, and your body is going down, and the central nervous system is telling that muscle to relax, and then it kicks in. This is the stretch reflex to prevent you from actually hyperextending, maybe ripping the muscle away from the bone. We talk about two components of that. It's the dynamic and the static. And I think of that like the dynamic would be the Navy SEALs, and they rush into an area and secure it. So it's a very quick, fast response, and it gets you out of danger. Then the ground troops come in, and that is the static, and they are going to stay there until the situation is resolved and you're out of trouble. The body is a wonderful, wonderful mechanism, and it has many responses that always try to keep you on an even keel, and this is just one of them, but it's trying to help prevent you from injury. The Golgi tendon reflex, it's also called the inverse myotactic reflex, because it is the inverse of the stretch reflex. If you think about it, when you lengthen your arm out, you open up your elbow, you extend that, these muscles have to relax and these muscles have to contract. Then when you flex, these have to flex and these have to relax. So you continually have this symphony of the muscles working together. In summary, the stretch reflex acts as a feedback mechanism to control the muscle length. So it's going to stop you before you hyperextend. Then in contrast, the tendon reflex operates as a feedback mechanism to control the muscle tension by causing the muscle relaxation before the force becomes so great that tendons might be torn. These are muscle spindles. They're located in the belly of the muscle, and they are typically still active when you have a neurological problem. They measure rate and velocity, and they get excited when the more you stretch, the more excited they get, and they're firing. We'll pause here, and the next segment will be adaptive tissue re-lengthening. Thank you.